Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information. Hi everyone, Dr. Pat here. Today's Quick Kick is a replay of an earlier episode about endometriosis, fertility and pregnancy planning. You may have heard that it's been a difficult few weeks for women with endometriosis and their carers. A Melbourne gynaecologist has allegedly provided surgical care for endo patients that falls well outside acceptable guidelines and practices. Women have been left questioning their treatment and the honesty and integrity of that provider. It's a reminder to all of us that the care we give our patients should be grounded in honesty and technical skill. It's also a very timely reminder that endometriosis is a multi-system disease best treated with a multidisciplinary approach. Surgery is so important for diagnosis and management, but multiple large surgeries are rarely needed. A team approach to ongoing symptoms should be part of the care plan for every woman with endometriosis. If you've been affected by pelvic pain or endometriosis, I hope this episode is useful.
And we've titled this one, Getting Pregnant When You Have Endo. Now, we talk about endo a lot in our household. Even though we do have 4 boys, it seems quite strange that we talk about it a lot. But we talk about it a lot, basically, Paddy, because it really impacts your work. You have a lot of people with endo at work.
Yeah, so within the gynecology part of my practice, a lot of it is young women with pelvic pain, and a lot of those have endometriosis. And we've been thinking a lot about, how does this fit in with a pregnancy program? And I think it is really relevant because if you've got endo, one of the things that you worry about is your future fertility. And today we're going to be talking about when you've had your endo treated and so forth, and now you come up to wanting a baby, how are things different?
Yeah, and you've got a bit of a special interest in endometriosis, don't you?
Absolutely. So right now I'm on a terrific committee at the College of Obstetricians and Gynecologists working on an endometriosis public awareness program and a screening tool and a GP education program.
Yeah.
So the college have got some money, some federal government funding to develop those things, and I'm working with some really terrific people across different disciplines as well. So not just obstetrician gynecologists, but also anaesthetists and GPs.
Yeah. Sort
of pooling our energies to come up with a really great product.
And those specialists are throughout Australia, aren't they?
Yeah.
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 So really, it'd be interesting for everybody to hear, I'm sure. Why are you doing that? What's the main sort of objective of that steering group?
Look, I think what we're trying to do is narrow the time frame between people developing symptoms of endometriosis and getting diagnosed and properly treated. Yeah,
because the diagnosis time is pretty horrific, isn't it?
Yeah, there's a figure sort of bandied around of 7 years between someone, on average, between a young woman developing symptoms that are fairly convincing for endo and her actually getting a proper diagnosis and treatment. It's miles too long.
Miles too long. And when you say young women, we're talking teenagers too.
Yeah, so that's one of the things that we're working on for educational programs. You can't really be too young.
Yeah.
So if you're 16, 17, there's no reason why you can't have endo.
Yeah. What we haven't done yet is define what is endo.
Okay, so endometriosis is a condition that's very common. It might affect up to 10% of women, and it's where tissue that is very similar to the tissue that lines the uterus and makes your period every month, that tissue crops up outside the uterus, commonly in the pelvis, attached to the peritoneum, which is the lining of the pelvis, and sometimes attached to other things like the ovaries or the fallopian tubes or bowel or bladder. And when it's out there, it causes pain, inflammation, scarring, painful periods, pain with sex, and obviously is relevant to someone who wants to have a baby.
And why is it relevant to somebody that wants to have a baby?
Well, there's lots of reasons why your endo might affect your fertility. You might be in too much pain to have sex, so you'll never get pregnant if you don't have sex, give or take. You might have the endometriosis still present in the pelvis, and we know that endometriosis nodules secrete substances that inhibit fertilisation and implantation. So fertilisation, sperm meeting egg, and implantation, fertilised egg, implanting in the uterine wall. So it's commonly seen in people seeking reproductive assistance. And then in women with severe endometriosis, it might be relevant to how well their pregnancy goes. So there's a whole sort of different set of considerations if someone who's known to have endometriosis is coming up to a time when they want to have a pregnancy.
And do you think that, women who have perhaps come up from their teen years with endometriosis and maybe they've taken 7 years to be diagnosed with it, do you think that there's an awareness that endometriosis can have an impact on a woman's fertility?
I think there's sort of an awareness based on education programs and so forth, but what we find is that there isn't a great awareness amongst that group about what should hurt and what shouldn't. So, we often see teenagers who think that it's normal to have an agonisingly painful period.
And days missed of school.
Yeah. So we're sort of working on better education so that we can help those people, those women, identify themselves.
Yeah.
Okay? And they can come to their GP and say, my period is way worse than everybody else's, than my peers, in pain. I've started having sex and it's super painful and so forth, and they can identify themselves as being likely to have a problem.
Are they the only symptoms that might sort of raise a red flag for a woman?
The big ones are painful period, pelvic pain at other times of the month, pain with deep intercourse, and then there's some people with severe endometriosis who don't have any symptoms at all.
Right.
And we only find that if they have a laparoscopy, say for infertility. As part of the investigation of why they've been trying for a year and haven't got pregnant, and we find significant endometriosis.
How weird that they don't have any symptoms, though, because it can be so debilitating for women, some women.
That's right. There's a broad range of, clinical manifestations. So we can have a woman with terrible pain and we can fully expect that at laparoscopy she will have bad endo. And we put the laparoscope in and she'll have one spot. And you take that spot out and she's fine.
Yeah.
There's another group who've never had a symptom in their life, have a laparoscopy because of infertility, and you find really quite bad endometriosis, but it wasn't troubling the woman at all. Wow.
So when you're working with the steering committee, are you working on what is the way to get diagnosed? How do you get diagnosed?
Well, there's a number of things we're trying to develop. One is the tool that a patient could use themselves, an online tool to say, okay, I tick all of those boxes. I'm going to take my 5 tick boxes to the GP and say, see, this says I probably should be sent to a gynecologist.
Yeah.
I think that's a useful thing. That's sort of patient education, helping them identify themselves. And then a separate tool which is about helping GPs to navigate the complex diagnostic process that endometriosis can be.
Quick question. Are you tired of the news? Do you want a podcast that isn't self-improvement? Come get Unleashed. It's funny.
I also think that underwear is sort of almost like a new marriage. Like it starts off, it gives you the best of what it offers at the beginning.
It's unhinged.
I have a bit of a thing for my friend's husband's salami.
Oh, hello.
It's not here to teach you anything.
I need to make sure he looks at me. One side, I'm going to make a sign. This is what I married because I didn't meet you in time.
Yeah, right.
The other side, with pointing to my son who's 12. Look what we could have had, Lewis.
Yeah, I love it.
It's a good time for Gen X. So search Unleashed wherever you get your podcasts. New episodes every Tuesday.
And is it only gynecologists that can confirm the diagnosis?
Yeah, so you can have ultrasounds and all sorts of things, but ultimately it's really only laparoscopy, an operation where we put a telescope in through the belly button and have a look at your insides, that can confirm the diagnosis.
Can we just describe a laparoscopy again, like in more detail?
So it's an operation where you come to the hospital, have a general anaesthetic after sleep for a little while, and we make a cut in the bottom of your belly button, put a telescope inside, fill your belly with some gas so we can see what we're doing, and use a bright light shone around on your insides to see if there's endometriosis there, and if there is, treated on the same occasion.
And what is treatment? What does that mean?
Well, if there's endometriosis there, we cut it out.
Oh, cut it out. Okay.
Yeah. So there's generally regarded that the technique to cut it out is better than the trying to burn it off.
Okay, so they've got terms, don't they? Because people know those terms, excision and...
Endo people know that, yeah. So motivated patients know about that. So there's a thing called ablation where you just use diathermy to try and sort of burn the endometriosis in position. And there's a technique which is widely regarded as being superior where you actually pick up each deposit and cut it off entirely.
Yeah, right.
Yeah.
Okay.
So excision better than ablation.
Okay. Because that, I don't know, that a lot of people talk about having ablation for their endo, don't they?
Yes, and I well, we're probably getting off topic a little bit,
Yeah.
but I think that's a probably, broadly speaking, an outdated technique.
Okay. All right. So the main treatment then is always laparoscopic surgery, or are there other treatments that you can do?
Well, I think a laparoscopy and surgical treatment is going to be part of everybody's treatment. But endometriosis is more complicated than just the surgical findings. And often a young woman with endometriosis needs a multidisciplinary treatment involving surgical gynecology, but also pain relief, also physiotherapy, also pain management clinic, maybe even psychologist.
And diet?
Yeah, there's some evidence that diet is relevant.
Yep.
Yeah, certainly it may well be relevant to the inflammatory part of it. So if you've got some endometriosis in your pelvis, the amount of inflammation that actually causes and the amount of pain it actually causes you, there's some evidence that diet might be relevant for that.
So if I am trying to have a baby, and I've had my endo treated in the early 20s and I'm travelling okay, I'm having some good and some bad days, as you do, and good months and some bad months for whatever reason. Now I'm about 28, because we like 28.
Yep.
And I want to try for a baby. What do I need to do now?
Well, I think this is the crux of it. I think this is so important, is that if a woman's been treated for endometriosis in the past, then she's really not any longer part of that sort of totally normal group of young women where we say to them, yeah, when you go off your contraception, start some folate, have regular mid-cycle sex and come and see the doctor if you're not pregnant in a year. If a woman's already been treated for endometriosis, the advice to her would be different. And I think that the number one thing that we would want that woman to be doing would be to assess between herself and her local doctor, how do we think the endo's really going? Yeah. So right now, and in particular when I come off my contraception. So she might have had a laparoscopy 5 years ago, and after the laparoscopy gone on a pill or a Mirena to suppress the period, and that might have been what got her through the next 5 years of relative comfort. And then we say, rightio, well, you want a baby now, come off your contraception, period's going to come back, so then we want to say, what's it like? Yeah. So if the period comes back and it's agonisingly painful, or sex becomes agonisingly painful, then we're not waiting a year. We're going to go back to the local doc, back to the original gynecologist, and work out what the endo's doing now. Yeah. Okay, before we potentially waste a year.
And is it likely that she'd need another surgery?
Well, maybe.
Yeah.
Certainly needs an assessment.
Yeah.
And then we might say, look, clearly, this looks like a recurrence, or that there's active disease here somewhere, and that before you go and try for a year, you might need an operation first.
Yeah.
Yeah. Or at the very least, we might say, well, try for a while, but not a year. Try for 6 months tops.
Yeah.
And if you're not pregnant, come back, and we'll repeat the laparoscopy or do some more tests.
Yeah. Is there a time frame if they do have a laparoscopy? Is there a time frame to wait until they start baby making?
After the laparoscopy?
Yeah.
No, just when you're comfortable again.
Yeah, right.
Yeah.
And for those women that perhaps find deep penetration painful during sex, and, it's an essential ingredient in baby making.
Sure.
Well, not the deep penetration, but sex is. What would you suggest? Have you got any tips?
Look, I think there are a couple of things about that. Number one is that if that pain is much worse than you've had in the past, then that has to be considered a possible symptom of a recurrence, and you might need to discuss that with your local doctor and your gynecologist. And then if you've got pain with intercourse and you're having intercourse more often because you're trying to get pregnant, then there are some tips that people can use, like taking anti-inflammatories before sex, that can really help to make women more comfortable so that they can have sex more often so that they can get pregnant.
Yeah. So there are some good sites. I think from the RANZCOG steering committee that you're on, we're starting to follow some really good sites on Instagram on endometriosis. So one that we've been looking at lately is Endogram. And this is by a woman, Brigid Hustlethwaite, who actually is a Triple J presenter. We really like what she puts up. She sometimes puts medical posts up, but mainly it's about her own journey and about the concept that endo is chronic, painful, needs support. It can be.
It can be. Yeah. So I think she's talking mostly about people who've got a serious and ongoing problem with it. Yeah. And she makes the point really well through her podcast that it's a multidisciplinary treatment.
Through her Instagram. Yep. And there's another one at Quendo AU, which also they run a support line for women that have endometriosis. And they've recently been given a grant, $480,000 from the Queensland government to put together an app for monitoring your endo. So it's probably good to keep an eye out for that.
Yeah, I think that's an interesting one because, again, it's building up a sense in the patient community that part of managing this well is the patient's responsibility.
Yes.
Yeah. Yep. So there's some really great gynecologists and pelvic floor physiotherapists and so forth out there, but they can't find you. Sometimes you have to find them.
Yes.
Yeah. And the more you know about your condition, the more likely you are to personally have an idea whether your symptoms compared to others are mild, moderate or severe and what treatment you might need and take some of the responsibility for finding that.
And if you are, in this stage and you're very concentrated on making a baby, then go back and listen to episode 2, which is how to track your ovulation like a ninja.
Yeah, absolutely. Yeah. So, because a lot of that advice is the same.
Yeah.
But I would say the two clinches are if you've already been diagnosed with endo, number one, come off your contraception and really assess what your symptoms are doing.
Yeah.
Okay, you may need further treatment before you can conceive. And number two, if you come off your contraception and feel totally fine, if you've had a history of endometriosis, then the 1-year rule does not apply to you at 6 months tops.
Yeah. And it's probably best to take a diary for these things.
Absolutely.
Really sort of be present and quite logical in how you're managing this process of getting pregnant.
Yep.
All right, to all our amazing listeners, thank you so much for joining us on this episode. We love having you on this journey and we hope that it's helping you have a very healthy and happy pregnancy and birth and move into your motherhood. So that's it for us for this week. We'll be in your ears next week. Until then, thanks so much.
Thanks for listening, everybody.
Bye for now.
Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.
Want to feel good more often in 2026? Hi, we're here for you. Move by Mamma Mia helps you fit movement into your everyday, giving you more of me time whenever you need it. From strength and cardio to yoga and Pilates with workout plans that fit every space, every body, and whether you've got 10 minutes or 40. Start 2026 with enjoyable movement from just $9.99 a month. Mamma Mia subscribers get unlimited access. Head to move.mamamia.com.au and use MoveMe to get $20 off an annual subscription.